Folks, like we are live in this series of conversations called BMT Experts, and today we have the honor of having none other than one of the best hematologists, Dr. Kannan Subramanian. So he lives in Pune and he practices with Sahyadri Super Specialty Hospitals in Pune and a couple of others. And essentially, like Dr. Kannan, he completed his MBBS from the University of Nagpur in 1995. Followed by which he did his DNB in general medicine and then clinical hematology, followed by a super specialty at none other than the Christian Medical College Vellore. He has been practicing over 25 years now and has been a part of about more than 700 transplants. So I don't think we would have, a more proficient speaker to talk on this topic of bone marrow transplants. So a warm welcome to you, sir. Welcome on the show.
Thank you. Can you hear me?
And I think, yes, sir, we can hear you very clearly.
Okay, thanks. Thanks for inviting me to this BMT Foundation sort of opening batsman. Thank you for that. And good morning to everybody who is listening to this.
So our honor to have you on the show, sir. I think BMT is becoming, like one of the most preferred options for a lot of blood malignancies. And given the data last year, I think India has performed close to 3,000 bone marrow transplants. However, the expected number of transplants that we may have to do to kind of really make up for so many patients who are is close to 75 to 80,000 is what we hear from the data. So we still have a large gap, and I think it's a growing number of this thing. So just wanted to kind of, before we jump into the actual transplant thing, we'd like to hear about, how did you kind of come into this space of hematology and then followed by the super specialty of transplant. So we'd love to hear a little bit of the personal side of that too.
Okay. The most interesting part would be that I was always interested in biology, but I was afraid of doing dissections, and so I thought I would become an engineer, but then I scored very well in biology and ended up being a doctor. And once I finished my MBBS, medicine was my choice. And during the course, when I was doing my medicine, I met Dr. Shashikant Apte, who is my mentor. And that actually brought me to hematology as my interest. Because it is a subject which primarily deals with blood, but it's not a lab specialty per se. So you are actually seeing your patients, which is what I always wanted to do. And then you could also incorporate many new findings, many new therapy, which could directly come from what we call from bench to bedside. So that was my primary interest. So most advanced knowledge, which can be directly applied to your treatment, and that was interesting for me. And I have become a hematologist now, and so anything to do with blood would be hematology. And to put it very simply, blood is like cells and plasma, which is the liquid component, and it consists of three essential cells. So RBC, red blood cells, then white blood cells, which are involved in typically fighting with infection and immunity. And you have platelets, which deal with clotting of blood. So to put it very simply, red blood cells increasing in numbers, so increase hemoglobin, decrease hemoglobin. WBC would be increased risk of infection, and also that would define leukemia or lymphoma. Those are cancers of white cells. And then you have platelet, so increased clotting of blood, decreased clotting of blood. So that would be leading to increased bleeding. Would sort of put a summary. And you have situations where all these cells can decrease, or so you have failure or aplastic anemia. So this would broadly be what we would be dealing in hematology. So that would include both cancerous conditions and non-cancerous conditions.
Okay. Fantastic. I think, that's a great overview of hematology per se. Like now moving on to the basic question of just bone marrow from a very simple man's language, because everybody considers bone marrow to be a big operation, बहुत बड़ा operation है, there is so much going on. And so can you just demystify or desimplify us for us in that sense?
Yeah, so I would agree to that. So we have had patients telling us that it's almost like black magic. That is how it is considered. But to put it very simply, so bone marrow transplant, the first line would be that it is the proven stem cell treatment which has been available to medicine for past almost 50 years. So the proven stem cell therapy, because when you call something as stem cell therapy, there is a lot of misconceptions associated with that. So bone marrow transplant is a proven stem cell therapy, but so when you say that stem cell therapy, it means that you are talking in terms of the cells which ultimately produce all this RBC, WBC, platelets in your body. And that essentially happens inside your bone marrow. So that is the second route where the misconception appears, because when we are talking of transplant, very simply put, we are changing the stem cell. So we are taking stem cells from a donor or a source. Okay, I will come to that again, because that can again be different. So you take stem cells from a source and then again put it back into the recipient, which is typically the patient that we are dealing with. Okay. So these are the cells which produce your blood, which would mean RBC, WBC platelets. So this would also mean that in the patient, we are actually changing the immunity for the patient again. Okay, that is to put it very briefly. And then, should I talk more, or you have questions?
I think I'll just move to the next question in terms of, like one of the fundamental questions people all of them understand is like, this is like the last option available for a blood malignancy beyond which we cannot do much. So either there is a kind of a, like a chemotherapy process that people follow and they say, "Arey, isse theek ho jayega, you'll be fine with this." Or then there are targeted therapies which are specifically available for lymphomas and stuff. And then there is a bone marrow also. So can you help us understand what is kind of, when do we look at a bone marrow transplant?
Okay, so to simply put, you can understand or the necessity of transplant being, so if you have a patient who has a problem with the stem cell transplant, and that problem can be understood as simply being stem cell being absent in the patient. Okay, that's one problem. So when you have no stem cells in the patient, or the stem cells not working, which again can be genetic or acquired. Okay, so you can be born with certain problems which will create problems in your stem cells which produce blood.
Like it could be thalassemia, sickle cell. Right?
Exactly. So you have thalassemias, sickle cell anemias, which are problems of the stem cells which doesn't allow it to function, and so the blood is not produced. But when we talk of, say, thalassemia and sickle cell anemia, that's specifically targeting the RBC component of that, or the red blood cells. You can also have similar problems associated with WBCs or platelets. Okay, so when it attacks the WBC, you're talking about immunity. So a person can be born with absent immunity, and that immunity can be again classified as T cell, B cell, immunoglobulins, right? So that can be one part. Likewise, you can have for the platelets also, or you can have for all these three cell lines. Okay, and this can be genetic, you're born with it. Various syndromes. Okay, Diamond-Blackfan syndrome, combined immunodeficiencies. Likewise, you have associated with only platelet problems. Okay, which will lead to bleeding. So all this will be absent cells or decreased function of cells, which can be either genetic or acquired, or you can have the various cancers, right? So where you get a particular cell which have lost control of the body. So it's like running amok. It's like a gunda inside your body. which doesn't allow other things to function, and that can become either a leukemia or a blood cancer or a lymphoma. Okay. So when you have to replace this, so when something is absent, you just replace. So that is more simple to understand. So like in combined immunodeficiency, thalassemia, sickle anemias, you knock off the present stem cells with a chemotherapy. Okay. So you make space. So it's more like agriculture where you prepare the land for putting the new seeds in. Okay. And that would involve removing the weeds and things. So you give a chemotherapy, knock out the abnormal cells which are present there, and then you replace it with a stem cell, okay, which will produce normal cells. Okay. And when you're talking about, say, a transplant in a condition of leukemia or lymphoma or a cancer, what it actually does is two things. One, before the transplant, you will actually give a chemotherapy to knock off the abnormal cells present in the patient. That's one. And the second thing is to replace it with normal cells. But when you're replacing it with normal cells, what it actually also does is it changes the whole immune system of the patient. Okay. So theoretically, what you're saying is you had a cancer in the first place because your own immunity was not able to recognize those abnormal cells. Okay. So you are replacing it with another immunity which will do that for you. That is what transplant will do for you. So you are acting on two things. You are knocking off the cancer by giving the chemotherapy, and then you are putting the other immunity which will sort of continue to do that stuff, check for appearance of new cells and knock the cells off. So in effect, that is what you're doing by doing a transplant. But in today's era, there are other things too apart from transplant, because ultimately transplant is a type of cellular therapy, right? And you can do that without doing so. The newer generation, what we call as CAR T cells and other cellular therapy, NK cellular therapy, are actually coming in this space, and that could change over a period of time how we end up doing a bone marrow transplant.
Okay. So we'll come to the newest therapies, I think, towards the end of this thing, because CAR T currently is so unaffordable in the country, and even in the other parts of the world. That we'll come to that in the end. But just looking at the next step, when do we suggest an autologous transplant versus an allogenic one? I think the basic question people have is
correct. So to essentially put, you have basically two major types of bone marrow transplants. Okay, one is called an autologous bone marrow transplant, or that is also called as autologous stem cell therapy, autologous peripheral blood stem cell therapy. That's one. Or you have the allogenic bone marrow transplant. So essentially, to put, you have, when you do a transplant, you have two things. One is the source, one is the recipient, right? So when the source and the patient is the same, you call it as an autologous transplant. So you are taking the stem cell from the same patient and then again infusing the same cells to the same patient. Okay, that is an autologous transplant. And the allogenic transplant is where you have a donor who gives you the stem cell therapy and then you put it on to the patient. So the donor is different, the patient is different. Autologous donor and patient both are the same in an autologous transplant. Now, you cannot do, the indications for both may not be the same. Okay, there are certain conditions where you will end up doing an autologous transplant. And in certain conditions, you will choose an allogenic transplant. And there are standard sort of situations where you will end up doing that. Okay. So essentially, to put simply, there are sort of in majority, not majority. So in a lot of myelomas, you will end up hearing autologous bone marrow or peripheral stem cell transplant. Likewise, in lymphoma relapse, or rarely first up, you will end up doing autologous transplant. And the third indication is many of the autoimmune disorders. So one of the immune disorders where we are seeing a lot of autologous transplant being done is multiple sclerosis. Okay, that is again a neurological problem where because you are able to change or reset the immune system, you are actually able to do autologous transplant and help people with multiple sclerosis. So and likewise, you can do it for a lot of autoimmune disorders, which means that your immune system is running amok, and instead of attacking the infection or cancer, it ends up attacking yourself. And in many of those disorders also, autologous transplant becomes part of your treatment armamentarium. Okay, and allogenic transplant, obviously, see, in genetic disorders where you are born with abnormal cells or absent cells, your own doing an autologous transplant is not going to be option at all. You have to end up doing an allogenic transplant because you're looking at getting normal cells from a donor. Okay.
Correct.
And again, in allogenic transplant, there are types of transplant. So it depends upon what you're doing. So before going to that, again, when you're talking about autologous and allogenic transplant and the source, I told you the bone marrow itself can be the source of stem cells or peripheral blood stem cells. Okay.
Right.
So when you're talking about bone marrow as being the stem cells, you actually collect the stem cells by doing a bone marrow, and that is called a bone marrow harvest. The patient will be given anesthesia, he will be taken into the OT, and then we actually harvest. So we put needles on both sides. So when you do a bone marrow, you are actually doing a bone marrow from the pelvic bone or the hip bone from the back side. You put needles and you poke again and again and again and again. So you might end up doing this 200, 300 times a poke, because each time you can draw only 2 to 3 ml. And I might end up collecting something like 300, 400 ml. Okay. So that is directly collecting the stem cells as bone marrow. Okay. But you can also collect the stem cells from blood. And how you do that is, to the donor, you will give what we call as stem cell stimulating injections, which is given for 3-4 days. And then you take the patient and put him on something like a dialysis. Okay. So here the blood flows from the patient to a machine. The machine will then collect stem cells as a collection. Collection might be
essentially separates the stem cells and the blood, is it?
Exactly. And the flow occurs continuously, but you end up sort of processing, say, 15 to 20 liters. Okay. Obviously, a person doesn't have that much as one go. So what the machine does is runs your blood 3 to 4 times across the machine. So if you have, say, 5 liters, your whole volume is run through the machine 3 to 4 times. While collecting the cells, and the machine will return the blood and the other components back to you. And the ultimately collection, what you do looks like blood. Even the bone marrow collection that you do looks like blood. It doesn't look anything different. Okay. So essentially what I'm also trying to say is, when you're doing a bone marrow harvest or a stem cell collection, there is actually no surgery involved for the donor or for the patient when you're doing the autologous transplant.
Okay.
No surgery involved. It is poking a needle and collecting what you want to collect. And likewise, when you are infusing this stem cell to the patient, there is no surgery again. Okay, that is the beauty of the whole procedure. You just infuse the whole product like blood through the peripheral blood or a central vein, and the cells actually know where to go. So they will go into the bone marrow. That's where they are supposed to go. And then over a period of time, they will start functioning, produce new cells, including RBC, WBC, and platelets in the patient. So
I think one of the key questions people always have is there a difference between what was done earlier, which is the bone marrow to bone marrow, versus peripheral blood collection of stem cells? So is there a difference in the way how they will go and settle in the body, or is it pretty much similar?
The cells essentially know. The cells essentially know whether you take it from the bone marrow or whether you take it from the peripheral blood. But the only difference technically is, when you collect from the bone marrow, what kind of cells come up, and when you collect from the peripheral blood cells, what other cells come in the component. There can be difference in the number of lymphocytes or the number of mesenchymal cells, which ultimately might have a difference in the amount of GvH that you will end up having. But that is theoretical. And for most of the stuff, the primary treating physician will decide a bone marrow is better based on certain advantage or disadvantage versus PBSC. And in the ultimate run, it might not make too much of a difference. So, but yes, there is some science to what you're doing, whether you are collecting a bone marrow or whether you are collecting a PBSC, and pluses and minus for both of them. But with present type of therapy that you do, so even after collecting the cells, you can actually play around with the T cell numbers, the B cell numbers,
Right.
or the stem cell numbers, and that can actually again change the whole scene for you.
So now I think we'll move back to allergenic because I think we still had to cover that bit. So yes, sir. So yeah, so autologous, I think we've covered where the source and the recipient are the same. Now I think we were talking about allogenic, where there is something called as an HLA typing which happens, and so can you from there then take on to the procedure of allogenic?
Okay, so looking at the procedure, when we talking about blood transfusion, blood chadana hai, so then the first step to do is whether the groups are matching, right? And when you talk about a blood group matching before transfusing somebody's blood, you're talking about the matching based on only red blood cells. Okay, so what we need to understand is when we are talking about the bone marrow transplant, the blood group matching is not essential. So you can have two different groups, but still you can match because what we are trying to match is actually the groups on the white cell, which is what the stem cell is a type of white cell. Okay, and that is called as HLA, the human leukocyte antigen. Simply put, it is white cell antigens. Okay, so when you are doing an allogenic transplant, you are trying to match whether the donor and recipient is a complete match or not. And based on that, again, there are types of transplant. Okay. So you are looking at HLA match, but you, based on doing the type of doing the transplant, you can have the degree of matches because that is also possible. In today's era, you can still go ahead and do a bone marrow transplant without having a complete HLA match. Okay, so HLA match, we will do matching over 10 or 12 antigen or places on the cells that you're looking at match for. Now, you can have completely matched transplant and mismatched transplant. So these are the two types of transplants. And when you have complete matched transplant, you can again have a completely matched sibling donor. So he's related to you. So completely matched related donor. Or in today's era, you can also have completely matched non-related donor. Okay.
Okay. So somebody outside also
a family match. Okay. So you can do a transplant like that. And again, when you're doing mismatched transplant, you in today's era, you have something like half matched transplant or haplo-identical transplant, which is typically your brother, sister, father, mother. Okay. And rarely you can have mismatched transplant who is not related.
Okay.
Why all this is happening? The first question, no? Why we should have so many different type of transplant? That is primarily because you do not have donors who is completely matched with you. Okay, that is where the whole problem is. So in ideal scenario, if I have a completely matched related donor, that makes my life simple, which means that you have a brother or sister who is completely matched to you. But the problem is the chances of your brother or sister completely matching with you is around only 30%. Okay, and that is that. So which means that 70% of your patients do not have donors to take cells from. Okay, and that is why for a period of time people understood that you can take brother or sister which are half matched with you, and that increases the chance that you have a person where you can get this stem cell and do the transplant.
Okay.
But why we were not able to do the transplant was, even if it was completely matched with a brother or sister, we could check only say 10 to 12 cases where it is matched. But we know that that is not true for all the antigens we are not testing. Okay, so complete match is only where we have tested. So there is going to be some differences which are going to be there, which we are not able to predict. And that is what will ultimately lead to problems. So when you do a transplant, you are infusing these immune cells into the donor, which will circulate inside the body of the patient and say that this body is not mine. So this skin is not mine, this liver is not mine, this heart is not mine. Because these immune cells over eons and centuries, they have been trained to identify these differences and then attack. And that is how they identify between self and non-self. And that is how they recognize infection. That is how they recognize, say, even cancers, saying that there is a mismatch, so they will knock off the cells. Okay, and that is, so we are trying to break this barrier and then try to make these cells accept the body. Okay, and that is why in a transplant, as against, say, a kidney transplant or a liver transplant, where you have to give medication throughout the life, we do not have to do that. But once these cells accept the patient's body as their own, they will stop attacking, and then you can stop all medications. And then when you say not attacking, you're saying it doesn't attack normal organs of the patient, says these are mine, but continues attacking the infections or the cancer cells. And that is what we want ultimately in a case of bone marrow transplant.
So are you also in a sense indicating that in an autologous transplant we have much lesser these kind of complications related to the other organs, because it is your own.
So in an autologous transplant, correct, absolutely right. So there is no immunological barrier that we have to circumvent in an autologous transplant, because it is the same cells from the same body. And the problems of what we call as graft versus host disease, which means that the cells recognize the body as being different and start to attack, is not there. And that is what is not there in an autologous transplant. So autologous transplant much simpler. The risks are typically only related to chemotherapy, which means that you have to undergo, your cells will come down. So infection is your primary problem there in majority of cases. And then it gets accepted and you're fine. So that happens typically in myeloma lymphomas, whereas in allogenic, GvH or an immunological barrier needs to be circumvented, and that happens over a period of time. Okay, so it might take 1 year, 2 years, 3 years. Once that happens, you can stop all medication and patient is fine. But the immunological barrier is something that you cannot predict, and that is what makes allogenic transplant more difficult than your usual transplants. Autologous transplant.
Sure. And are there also cases in allogenic where the body can straight away reject the stem cells? Are there cases that we kind of also come where in spite of the HLA match, the body says, look, this is not mine?
Yeah. But generally, the chances of rejection is much less than the chances of, say, GvHD. So you're talking in allogenic transplants, it's, say, in the range of maybe 2% or less, the chances of rejection. So, and the chance of rejection increases as the mismatch increases. And that's why a haploidentical or a half-matched transplant is much more difficult than a fully matched transplant. But with today's era of the kind of medications that you use to address that issue, the risk of rejection has. So even now, the main problem with any allogenic transplant is, one is the disease coming back, especially in cancers. Okay, in spite of a transplant, you can end up having a relapse risk. And the other major risk is the GvH. So the bane of allogenic transplant is GvH, the immune cells not recognizing the patient as their own, and the rejection. Rejection is a very small. In most of the transplant, it is definitely less than 5%. You're actually talking in the numbers of 2 to 3%, not more.
Okay, so interesting. I think there was a question that came up like from one of the comments on the Facebook, and it was asking, saying, is a 100% MUD, matched unrelated donor or a haplo, how do we compare these two, and which one could be better in what situations? Was a very important question somebody asked. Because in the mud, there was a match they found in the US. And incidentally, the doctor was saying that he's a Caucasian and a Hispanic, and these are words that we don't understand as simple.
Yeah, truly speaking, it is again a difficult question to answer. When you are talking about these kind of questions, you are trying to answer, say, in a group of 100 people, what is happening.
Right.
And to extrapolate it to a single person and single patient's response is very difficult. Okay.
Okay.
So to broadly put it, you have to try and answer these questions more case-to-case basis. So what disease are you treating and comparing for mud and haplo? What is the disease you are treating? That's one. And when you are talking about, say, a cancer, you are also trying to talk about, is it in the first CR or is it a first relapse? Or when you're doing the transplant, is the patient is in complete remission? Minimal residual disease absent, or is this is a non-cancerous condition where you are talking of situations where you do not want GvHD. So to simply put, when I do a transplant for allogenic transplant for a cancer patient, I would want a little bit of GvH, or the graft versus host, to be there, which tells me that that kind of immune interaction will also knock off the cancer cells in the patient. Okay. Whereas when I'm talking about thalassemias, aplastic anemias, I do not want GvHD at all. Okay. So in those kind of scenarios, each step, like, is it a completely matched sibling or a matched unrelated donor? Because immunologically, again, these situations are actually two different situations, not same, though they are completely matched. When you have a family donor, in the places or in the antigens that we are not testing, we might be similar. Okay. Whereas a matched unrelated donor, though he is similar because he is from a total genetic pool, at other places he might be different. Okay. And that increases the degree of unpredictability of an immune response. Okay. So same is true with haplo.
Correct.
So it all depends upon. So when you're talking about haplo, you're talking about brother, sister. So you are inheriting half from the father or the mother, which is similar, and half is non-similar. Okay. And that non-similar, what it ends up doing can be very tricky. Okay. So you cannot have a generic response as to a mud is better than haplo. Okay. So in a particular situation, for a particular situation, you can have actually haplo better than mud.
Okay. Got it.
We can also, we might end up arguing that between doctors also. But the second thing is, between team of transplant physicians, you might not have an unanimity between a mud is better or a haplo better, because the both answers might be true.
Interesting.
Okay. So these are not simple generic haplo better than mud. Hopefully, we will be able to answer that kind of questions more easily. But at this point of time, we still don't know. But what we are realizing is that slowly haplo is catching up with mud, and mud is catching up with matched sibling donor. And we truly believe, if we can come to, so if we have come to a situation where haplo equals matched sibling, then the biggest benefit will be for the patients, because we would believe that each patient will have a donor. We will not have a situation where we are not able to do a transplant because there is no donor. So I really want haplo to be equal to MSD or a mud.
Oh, wow.
And
and also the database needs to
reaching there. We are reaching there.
Correct. And the second is also increasing the database of people who will come forward and donate, so that when the mud becomes like a actual transplant, we have that many donors available, because so many patients must be missing out on that in terms of not being able to find and then.
So that is how the whole mud came up, because we knew that if you do random matching and you have a huge database, we should be able to find out donor for most of our patients. So, so if you combine haplo, mud, MSD together as a donor pool, then in today's era, most of our patients will end up having one or the other donor. Okay, and I think we missed one about umbilical cord as being the donor. No, we have not talked about it, right?
Yes.
So when we talk about the source of hematopoietic stem cells, or the stem cells which are producing the blood, umbilical cord also can be used as a donor source. And there, how it works is, when a baby is born, the umbilical cord cells are separated, and that can be stored, and that can be used for some other patient. But again, there is a lot of misunderstanding, because patients do call me and ask me, I have a child, and should I store that? So when you talk about storing the umbilical cord, my opinion, okay, this is my opinion, you should not do that as a private cord banking, which means that you're storing the stem cells for use of your own.
Only yourself,
yourself. So that becomes your private cord banking. I think that is a wrong way to do it, because ultimately that never gets used for yourself.
Okay, got it.
So you should not. It is a waste of money. And sorry to say that it's more like a scam that is happening at present. You should do that as a public cord storing, because then that can be used for somebody. So in an Indian scenario, umbilical cord transplant is really tough to do because of the recovery times from the umbilical cord and the kind of infective complications that we have been facing. So I don't have much experience with umbilical cord transplants due to that reason.
No, great. And let's talk about the next gen therapy, which I think you hinted in the beginning, which is the CAR T therapy. What is CAR T therapy about?
Okay, so it's to put, say, science sci-fi into action. It's like arming your own soldiers with better armamentarium. So you make super soldiers out of your own immune system. Okay, and there also, so I'm talking about your own immune system. So it is going in two ways, that you take your own T cells or even NK cells slowly. That is also coming into play. So when you talk about CAR T, you are talking about your own T cells.
Okay.
So to break down that, you have immune system, which is cellular and which is dissolved in your plasma. The plasma is a protein which is called as immunoglobulin, and then you have cells which are lymphocyte, okay, which is part of your immune system, your own soldiers, and then these lymphocytes are again divided into B cells and T cells. Okay, so B cells produce immunoglobulin, which are proteins which help in your immunity. Okay, and then T cells are again immune cells which will directly fight the infection. Okay, but they also work with B cells for production of immunoglobulin. So they are not working separately as we believe. So they are hand to hand, and they help in the overall immune system. Now, so as we understand, basically we understood that it fights infection, but immune system have other functions also. So they are supposed to look for cancer cells and knock them off in your blood circulation. Okay, that happens with T cells also and NK cells also. Okay, now what we are doing in the space of treatment is, we know that the cancer is not getting cured because these T cells are not able to go and identify the cancer cells. Okay, so the whole science of that is, you make them identify certain antigens or certain markers which are present on the cancer cells. Okay, that is how you do it. And how do you do that? By doing genetic engineering. Okay, so you take the cells and then infect them with, so make them able to identify certain markers on the cancer cells. Okay. At the same time, you also give them guns, right? Once they identify, they are able to shoot those cells. So it is like a directed attack or a concerted directed missile attack on the cancer cells. Okay, that is what CAR T cell.
So on a lighter note,
very broad term,
creating a team of Avengers to kind of go out and kind of
exactly,
cancer.
exactly. You could actually say that you are arming you. So you take these cells, take them out, put them in a machine factory where you are able to give them cognate receptors which can go and identify these cancer cells. Okay, they can be armed to identify these cancer cells only, and then discharge a payload into the cells and destroy them. The advantage would be these cells can multiply in your body, so the numbers can increase and they can go and directly attack these cells. And that's what is happening. So slowly it is happening for lymphomas and leukemias, more for lymphoid leukemias, less so for myeloid. So at this point of time, there is CAR T cell therapy available for diffuse large B cell lymphoma, likewise for. So many times what happens is it acts as a supplementary or a complementary to your bone marrow transplant. So you can have this CAR T cell to first clear the disease and then do the transplant. You can have scenarios where your transplant has failed and then you end up putting a CAR T cell. So they can be sequenced in different ways. We're still understanding which is the best way to sequence. In certain scenarios, they will give you long-term responses, but maybe in the range of 20 to 30%. What we need to understand is whether you talk about transplant, whether you need to talk of CAR T cell, none of them are effective for 100% of the patients for 100% of the times. Okay, so you might end up using sequence them in one way or other to give better responses. Okay, but so a CAR T cell therapy is again a cellular therapy without the disadvantage of having a transplant. But in certain scenarios, you can actually do a CAR T cell therapy and then do the transplant, because then CAR T cell transplant will completely cure you.
Okay, got it.
So we are still working with the various recipe of how to combine various cells, how to arm those cells, what kind of payload to use. All those things are still a moving target at this point of time.
Sure. Fantastic, sir, and thank you so much. I think we are, now, like just 15 minutes away from time. So just to keep a tab, I think we'll move into Q&A if that's okay with you, with very short answers if you can.
Whatever I can.
And I think, no, absolutely. And one of the comments that has come was my brother is diagnosed with AML. And they have suggested an haplo match because obviously they haven't been able to find a mud. So is that okay? I think the question is that is that
definitely haploidentical transplant? Yes.
No. So that's the question.
Yes, definitely. If it is a relapsed disease, haploidentical transplant is definitely a good option for AML.
Okay, fantastic.
Okay.
And then there was one question with regard to this young kids getting cancer, pediatric, and not necessarily cancer, but also certain conditions. Like there was one called hemolytic anemia, and then there was A-gamma globulinemia and stuff like that. How do you even identify? Are there now tests available where people can really go to that level of group?
Yes. Thankfully, that is the beauty of a blood-related problem, because it is easily accessible. You don't need to do a very complicated surgery. It is a simple collection of blood sample, and in the hand of a good pathologist, in the hand of a good hematologist, it can give you a huge amount of data. So thankfully enough, yes, we are seeing more number of ALLs. I think that is also partly due to the fact that people now understand blood tests have become more accessible. At most of the places, it ends up being an automated procedure, and the machines are also good enough to say pick up or in our this one we say that we flag. We flag. So any abnormality can be easily picked up by a machine, and then also with slowly increasing number of specialists and easy accessibility, you are able to diagnose it much faster, much easier. So it's part of the actually solution rather the part of the problem. Now, whether many patients do question me whether fertilizer, use of fertilizer, use of weeds, the way we eat our food, the way of
growth factors,
and electromagnetic exposure, X-rays. Possibly these are all part of the problem. Okay, but how to find solution to a more wide use of weedicides, chemicals. So that has to be part of the way that we live our life. I think that is a bigger fish to fry or to cook. We don't know.
No, I think that's also a huge problem, because given the fact there was a report I was reading from Cuddles Foundation that was published recently, and I got to kind of read the report yesterday, and it said that maximum number of the kids are kind of detected with ALL as a complication, and it's becoming so rampant.
No, that is see primarily that problem
is it because
no in children blood cancer is the commonest cancer. Okay, 90% of all the cancers are leukemias. Okay, so that is what you will end up seeing. Okay, and that is also true because you do not know the cause of cancer. So this is not due to some exposure typically. Okay, that is the primary thing. Sure. Okay, we do not know why a leukemia happens. So is it due to something that we do or we did not do? We do not know. I end up telling all my patients, because their question is, हमने कुछ किया क्या, हमने कुछ खिलाया क्या? But actually we don't know the answer to that. Okay, and that is why there cannot be a preventive solution. But so the broader thing is, if your lifestyle changes, you adopt more healthy food habits, more healthy water, exercise, in the long run, all that can impact to a more healthy immunity, and probably that will impact into getting less number of cancer. That's what would I sort of think.
Sure. And I think one of the basic questions people ask when going into treatments like a bone marrow transplant or something, and I think it's a very emotional question also for people, like, will my patient survive? Or will my brother, will my sister, will my father, will my cousin survive this process? And how do you even answer such a question? Like,
it's actually a very difficult thing to answer. Because when we talk about 70% chances and 80% chances, even then actually there is a 20% chances where things are not going to work. Okay, and but that is how it works out, that I can talk to you about giving numbers to make you understand, but in the end run nobody really knows. Okay, for a given patient, his chances of survival is 100% or 0%, which means that he will get all right or not all right. But many times to really tell, there is actually no other option, right? So especially for a cancer patient, if he doesn't do that transplant, the bigger problem is the chances of survival is close to none, right? But to be able to predict that this patient will respond and this will not respond, I think science will never reach there, and that is the truth, right? I as a doctor, I will never, when I'm doing a transplant, I will never be able to predict whether this patient is going to be completely all right. That is the truth. So we cannot reach there. So as a doctor, my job is to give the best treatment options, and me, my patient, we are all part of the team, and will have to be a joint decision whether to go ahead with a transplant or not.
Wow. So you almost sound like a, this almost seemed like a spiritual question in the end. When you
Yeah, it
also
is
said that,
actually so. No, it is actually so.
huh?
Truly so.
Hmm, hmm, hmm. Right. So in fact, there is one more question from the audience. Is my sister is diagnosed with, I'm just going to read it out for you. And she's diagnosed with a BT-MPAL blood cancer, and she's a 50% match. The sister happens to be a 50% match haplo, and she has an American 100% match donor, and many 90% kind of match multiple donor in the national registry, but the doctor is suggesting to go for haplo. So, what's your take on that? Obviously, every doctor will have different opinion, but how do you look at this? And also, cost is definitely a constraint, given the fact that if you
So that is how ultimately you will have to address in an Indian scenario, because uh, 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 completely matched donor from America, uh, the cost of therapy will be beyond 50 lakhs. Okay, that is what you're looking at. So one of the question to answer would be whether we will be able to stretch out to that limit. Okay, and in these kind of scenario, MPAL, my belief is a haplo might not be too far from responses of a matched unrelated donor. Okay,
okay,
if
okay,
I had both the options, whether you will go for matched unrelated as against haplo. So this 50% match is who is the match?
so the sister
Haplo match.
happens to be a match sister.
The sister happens to be a match. Okay. Okay, and the age is 22. So I think in this question, probably a haplo would be as good as matched unrelated donor.
Fantastic,
Mud.
fantastic. So that kind of puts,
100%
the
mud. 100% mud.
right.
I will not go for
Sure.
a 90% mud donor. I would prefer a 50% sister to a 90% mud donor. That's for sure.
And just one very difficult question. As a doctor, you keep facing so many successes and so-called failures. It's not a failure of treatment, but we end up losing the patient. So at one end, while you see so many successes, we know that BMT itself is such a complicated procedure that we also
Absolutely.
lose patients. On an everyday basis, how do you deal with it, and what are some of, so how do you really look, and are there any practices that you would kind of follow for yourself? This is a very personal inquiry oriented question, in terms of how do you, every day you have to come back and again see new patients, again treat them, again take somebody for an option, and still end up losing some, and some people making out. How do you really do this?
The one thing that helps me here is um, for any of those diseases, even which reach say 80% cure or 70% cure or 60% cure, until I do, I will lose all those patients, right?
Hmm.
So it's not like a choice I have. If I'm afraid of doing that treatment for those numbers, I won't even reach that 70% cure. So that would help me, because without doing that, so inaction will still be worse than doing, right? That is one
Sure,
for
but
me.
even keeping equanimity intact, right? Because you meet every patient with a smile when you go to the next room, knowing that the previous one might not make it through the night,
Yes.
and still walk into the next person with the same smile. How
Yes.
do you
So,
really find that
the
balance?
other one is uh, it's more to do with my the spiritual aspect of that. So uh, I believe that in the true sense that you have to do your duty. You have been brought to do this world for doing your own karma. That's what uh, you are doing. And that is what you have to do to your best level. Okay, it might not be the best in the world, but it is to the best of your abilities. And I truly believe that giving the treatment is the right treatment. Doing your best is what you can do. The cure or the not cure of no cure part of the whole is actually to the Almighty, okay, to the God. That's where you have to pray. So it's not just you're giving the treatment. It is your prayers for yourself and also the patient, and that is what ultimately makes you able to face what you're saying. Your next patient, and still continuing with the treatment, not knowing in 100% reality that what the ultimate result is going to be. Okay, so I have my guru. I have my sort of spiritual practices, which helps me in dealing with that problem of not being able to cure all my patients. And like what you told me, I'm not sure at the start of thing that whether my patient is going to see. So whether 10 years after this, am I going to see this patient or not? Okay. Um, so it is my belief in God and possibly the philosophy of Hinduism, not specifically Hinduism, maybe our spiritual, ultimately, whether you look at Hinduism or, so it is that one God or one power which works through everybody. So the patient is also God, right? And ultimately you are part of the whole karma. So you do your duty, you go ahead and you do your best and hope for the best and also pray for the best. That's what happens to your patients, and that gives you
Yeah. And I
courage
think you
to.
made a very interesting, you made a very interesting statement during GvHD, saying identifying the non-self versus the self. And I think unless all of us find unity at a global level
Yeah.
and a cellular level, I think we're never going to be able to save the
So
whole
that
thing.
unity, of course, and that helps in
Yeah,
being able to deal with this.
fantastic. And just one last question before we end this amazing talk is what will be your top three suggestions for the family of patients when they're considering transplant?
What will be my, sorry?
Top three suggestions for the family who's considering a transplant.
Okay, top three suggestions. I think yes. One is to have open discussion with. Most importantly, is that to have open discussion, including everything. Don't be afraid to ask a question because it is silly. It is not. None of the questions are silly, and ask whatever. And have a straight dialogue, and that is very important because you need to understand. You have to be able to do a transplant with an open mind, because it's never 100%, right? It's not an easy therapy, so it's filled with lots of hardship. So you have to be bold enough, courageous enough to understand both the pluses and minuses. And so to have a more open, honest discussion with your treating doctor is the most important thing. And I think without that, it doesn't easily work out. So that would be my actually first, second, and third most important, to
Awesome.
have a very open discussion. And I mean, you have to go through that before you do a bone marrow transplant. I think that is very important.
Great. So thank you so much, Doctor. I think we have overshot the time that we had planned for today, but thank you so much. I couldn't be grateful for this
Thank you.
amazing and such clear and and just concise breakdown of this whole process of this complicated organ.
I just hope I was simple enough for all of our audience. The more difficult thing was, of course, we have talked in only one language. Um, uh, but I thought I was simple enough, but I think you would get enough feedbacks. And thank you
No,
for.
I think all of us, all of us really enjoyed this, and I think this is very clear and like a precise kind of understanding, which will help people understand the basics of bone marrow. Obviously, at every step there are different complications, and every step there are different questions that might arise. But I think primarily to have an understanding of bone marrow, I think this is significant. So really honored to have you, sir, on this conversation of the first talk of BMT Experts, and hope to have many more conversations around this as time pass by. So
And that
thank
would
you
be really
again.
fantastic. And I congratulate again you for starting this BMT Foundation. And I really hope you are able to do what you hope to by starting this. And
Absolutely.
I would cooperate in any way that you would want me to. Thank you.
Thank you so much, and thank you so much for your blessings again, and hope to keep continuing this conversation. Yeah.
Thank you.
Sure, sir.
And
Take care, sir.
thank you. And happy Sunday to all of you. And having